Hi guys, welcome to my channel. This is my third video. I have got massive response for my first two videos. Approximately I have got about 1400 views for my first video and 1100 views for my second video. Thank you so much for that. And from now onwards I have decided that I will be making two kinds of videos. One will be for the normal audience and one will be for the medical audience. So the videos which I will be making for the medical audience will be in English, and the videos which I will be making for the normal audience will be in Tamil. So guys, here in this video, I have decided to talk on the topic pneumonia. I have collected information from varieties of books and I am displaying information on this board so that you guys don't need to refer multiple books for the same topic. I'll be starting from the basic level and I'll be cruising through the topic one by one, and by the end of the video, I assure that you'll be knowing nook and corner about pneumonia and how to treat and so on. So guys, let's start with the video and let's fast forward what I write so that you don't waste your time. So guys, let's start with the today's topic, which is pneumonia basics and beyond. So pneumonia is defined as the infection of the pulmonary parenchyma. So pneumonia is basically classified into community acquired pneumonia, hospital acquired pneumonia, ventilator associated pneumonia and healthcare associated pneumonia. So you basically will be wondering what is the difference between hospital acquired pneumonia and healthcare associated pneumonia. So according to Harrison's, this is a new term which coins community acquired pneumonia caused by MDR pathogens typically associated with hospital acquired pneumonia. So this is like a community acquired pneumonia which is caused by multi-drug resistant pathogens. Coming to the basic pathology. So pneumonia basically occurs due to proliferation of microbial pathogens at the alveolar level and the host responds to the pathogen. And the most common route by which pneumonia occurs is by aspiration from the oropharynx. Aspiration from the oropharynx can be small volume aspiration, mostly occurs in elderly and persons with decreased level of consciousness like alcohol or drug sedated persons, etc. Some of the rare routes by which pneumonia can spread are hematogenous route from tricuspid endocarditis and contiguous extension from pleura or mediastinum. Coming to the natural protective mechanisms which protect us from getting pneumonia are, first of all, whenever we inhale some infectious pathogens or some toxic substances, our body initiates a gag and cough reflex, which by itself protects us from pneumonia. Next is the nasal hair and turbinates, which protect us from large particles. Then there is the resident microbial flora, which inhibits proliferation of the pathogenic organisms. And from that, the branching architecture, mucociliary clearance, and local antibacterial factors altogether play an important role in preventing the pathogen from entering into the alveolar. Then there is the resident alveolar macrophages, which by itself is playing the most important role. And this resident alveolar macrophage is assisted by the surfactant proteins A and D, which have intrinsic opsonizing properties. Once the bacteria is opsonized, it can be cleared by mucociliary elevator or the lymphatics. Coming to the risk factors associated with pneumonia, the risk factors mainly include hospitalization for more than equal to 2 days in past 90 days, use of antibiotics for the past 90 days, immunosuppression, tube feedings, and chronic hemodialysis. Risk factors specific for community acquired MRSA are any cavitatory infiltrate already present in the lungs of the patients, gross hemoptysis, summer month onset, and erythematous rash if present in an individual, they can be a risk factor for community acquired MRSA. So causative organisms for pneumonia can be divided into three: the OP, non-NICU, and ICU. So patients presenting in OP with pneumonia can be affected by some of these pathogens, which include pneumococcus, Haemophilus influenza, Mycoplasma pneumoniae, Chlamydia pneumonia, and respiratory viruses. And the non-ICU causes of pneumonia include Legionella species and all the species belonging to the OP category. Then in ICU patients, the pneumonia can be caused by Staphylococcus aureus, gram-negative bacilli, and the OP and NICU altogether. Then I'll be discussing more about pneumonia. So continuing with the topic, so when does pneumonia occur and why? Even after all the natural protective mechanisms which I have discussed, pneumonia occurs in some persons, and we will see why it occurs. So alveolar macrophages, once the capacity of alveolar macrophages is exceeded to kill the microorganism, clinical pneumonia manifests. So alveolar macrophages after that initiate an inflammatory response which release many inflammatory mediators, out of which the important ones are interleukin 1 and tumor necrosis factor, which promote fever in the person. And there is interleukin 8 and granulocyte colony stimulating factor, which are responsible for peripheral leukocytosis, neutrophils increase, and purulent secretions. And altogether, the inflammatory mediators released from the macrophages and the neutrophils promote capillary leak. So, what is capillary leak? This capillary leak is similar to the acute respiratory distress syndrome manifestation, but it is localized. And gradually, it can progress to generalized form. Normally, the alveolar epithelial membrane are close together, and on action by the inflammatory mediators, the gap junctions between the alveolar epithelial membrane separate and cause the capillary leak. So, the blood from the vessel, mainly the erythrocyte, can travel via the gap junctions to the alveoli and promote hemoptysis in the patient and cause alveolar filling. This alveolar filling leads to hypoxemia. This hypoxemia causes reflex hypoxemic vasoconstriction, which is a protective mechanism by the body to decrease the capillary leak, because the vessel gets vasoconstricted and there will be less capillary leak. But some bacterial pathogens even inhibit this hypoxemic vasoconstriction, which can prove very high mortality in the patient. And there is increased respiratory drive, which causes respiratory alkalosis in the patient. So basically, respiratory alkalosis is decrease in PCO2, and the compensation for the decreased PCO2 is by decreasing the bicarbonate levels. Therefore, there will be decreased bicarbonate level in the patients. So altogether, by summary, which are all the factors to decrease the compliance of the lung are capillary leak, hypoxemia, increased secretions, infection-related bronchospasm. So when severe, this can lead to respiratory failure and death in the patient. So I'll be continuing with the topic some more. So continuing with the pathology of pneumonia, pneumonia evolves through a series of pathological changes. The stages which you see here are specific for lobar pneumococcal pneumonia. So first there is the initial phase where there is edema with proteinaceous exudate and also some bacteria is present along with the proteinaceous exudate. Then following initial phase there is a rapid transition to the red hepatization phase where there is, as I have already discussed, there is capillary leak from which erythrocytes have leaked into the alveolar space, and that is the red hepatization phase where erythrocytes are present in the intraalveolar exudate. And bacteria can be demonstrated only up to this stage. Once red hepatization has been converted to grey hepatization phase, bacteria cannot be demonstrated. No new erythrocytes are leaking, and already there is hypoxemic vasoconstriction has taken place. Therefore, there will be no new erythrocytes. And already present erythrocytes will be lysed and degraded, and there will be neutrophil predominance along with fibrin deposition. And this phase represents a successful containment of the infection. Once this phase is cleared, there is a resolution where the lung regains its architecture, normal architecture, and macrophage again predominates the alveolar space. So, and coming to the alternative pathway, in Harrison's, another pathway has been mentioned regarding pneumonia pathology, which says that the pneumonia mainly occurs due to altered microbiota. Normally, there is gram-positive normal microbiota in the alveoli, and as all of you know, there is gram-negative normal microbiota in the gastrointestinal tract. So, many community-acquired pneumonia pathogens are component of normal alveolar microbiota. This normal alveolar microbiota gets altered when there are viral upper respiratory tract infection or there is antibiotic therapy given for the patient. When there is viral upper respiratory tract infection, it predisposes the patient for community-acquired pneumonia, and when the antibiotic therapy is given for the patient, can predispose the patient for hospital-acquired pneumonia or ventilator-associated pneumonia. So this is the end of today's video. Thank you for listening to the video. In the future, I'll be discussing about community-acquired pneumonia, hospital-acquired pneumonia, healthcare-associated pneumonia, and ventilator-associated pneumonia separately, and also I'll be focusing on interstitial pneumonia. And regarding normal audience, I have decided to talk about Nipah virus, which I will be dropping the video soon in a week or two. And thank you for watching today's video. Please subscribe and like the video if you have understood something, and please click the bell icon as well. Thank you.